Good afternoon, friends, colleagues, seniors, and very close family members. And let me recover from the words that Dr. Urman Bey, Dr. Jitendra, Dr. Shailesh Bey, and all the colleagues used for me. Well, really, I deserve them or not, I really do not know. But it is really an honor and privilege to be here representing RSSDI Gujarat. RSSDI, we all know, is the biggest and the strongest diabetes societies in the world, not only in India. And we are privileged to have with us Dr. Jyoti Dev, Dr. Jethwani, Dr. Harish, Dr. J.K. Sharma, Dr. Sunil Gupta, Shailesh Bey, Dr. Piyush, and Dr. Akash Singh, Urman Bey, Jitendra Patel, Manoj Bey, who are all very senior members of RSSDI here. Forgive me if I am missing some of the names. And I really feel very much honored to be representing this organization and as a chairman of RSSDI Gujarat chapter. So what I am going to do here in next maybe 20-25 minutes is, in the time that I have been given, I will not be presenting what I have did or we have did collectively, but what we can do going a way forward so that it can be very, very helpful to our colleagues as well as our patients, so that together we can improve the quality of life of our patients. So this is a blue index, which is a motivational health score. Probably some of you, all of you might have received the 4-page leaflet which I have just circulated. We know diabetes is a multi-system disorder. All of us have been talking about this, but in the last 7-8 years, since the SGLT2 inhibitors and GLP-1s have come, we have identified as a cardio-kidney metabolic disorder. But we have known this, that diabetes affects all the organs of the body. That has been taught to us right from our undergraduate schools, and in the clinical practice also we have seen. But none of the guidelines previously, before 10 years, suggested us a comprehensive control. Most of the guidelines were just glucose-centric, and in the clinical practice also we used to be very much glucose-centric, only to know that from the Accord, Advance and the Veteran Affair trials that glucose control does not play a very big role in prevention of the macro or the cardiovascular complications. Of course, done early, it is very important, no doubt about that, to prevent the microvascular complications, but its role in preventing the cardiovascular complications, which are the biggest burden in diabetes patients, because cardiovascular complications are the ones which kill the patient in the younger age. And that is why we needed therapies that would actually address the cardiovascular risk reduction. The global guidelines, whether ADA or IDF or even our RSSDI guidelines previously, were mainly focusing on the glucose control. Of course, in the last 8-10 years, all the guidelines have realized that glucose control along with the other factors control plays a major role. But we, when deciding the overall outcome of the patient, myself, Dr. Bansi, Dr. Urman Bey is here, Jitendra, Manoj Bey, Dr. Shailesh Bey is here, all of us were sitting in one of the meeting, and we saw that we need to take care of the patient as a whole. Holistic approach is which is needed for the overall management of diabetes, so as to reduce not only microvascular, but the macrovascular complications. We had several scores, like for diabetes development, diabetes risk score. For cardiovascular risk, ASCVD or Q risk or Framingham score. But these scores did not mean anything for the patient. If you tell your patient that your risk score is 21%, what he is going to understand? That my risk of developing heart attack is 20%? What I am going to do about that? Nothing. So no parameter or index which was patient centric, and that's why we thought that we should have some index or some calculation or some algorithm which would be patient centric. So we developed this index. Ultimately myself, Bansi and Urman Bey together decided that let us give name of blue index to this. So blue index is a term coined to represent the overall health of the patient with type 2 diabetes, not only the glucose control, where glucose control is obviously important, but there are other 9 parameters which are equally important. We have given equal importance to that because it is not a risk score. By measuring the score, we are not telling that X patient is having more complication chances compared to Y patient, but it is basically to engage, empower and motivate the patient for his own personal improvement in that particular area. So it is to assess the current diabetes care, to assess the trends in the diabetes care, to identify the persons who need the intensive intervention and to identify the areas in which intervention needs to be more intensive. Suppose a person is having good glucose control, good blood pressure control, but if his LDL is not at goal, we should be focusing more on that. If his follow-up is not regular, we should be focusing more on that. If he is not taking enough measures to prevent the infections, we should be focusing on that. So it is basically to identify the specific areas where we need to target more, and ultimately it can serve as a teaching tool not only for the physicians but also for patients as well as family members. So why the name blue? Because the blue is the color which is inspired by International Diabetes Federation, Unite for Diabetes, and that's why we have given the word blue index. We now have developed a blue index registry in diabetes, bird with peacock as its symbol. I'll show you that. So what is it actually? It is comprising of 2 parts. One is the health score, diabetic health score. The other is the complication score, which is KS. Health score, better, higher the score, better it is. Complication score, lower is better. So the score is categorized in 10 categories, 10 parameters, starting from A to J, alphabetically arranged. Alphabetically arranged. Each parameter is graded on a point of 6-point score, 0, 1, 2, 3, 4 and 5. Minimum possible score, if you are getting 0 in each, it will be 0. If you are getting 5 in each, the highest score can be 50. So maximum is 50, minimum is 0. I am not going into details how to grade or how to score because it's a little bit lengthy process. But the 10 parameters we have included here are categorized in the alphabetical manner. Starting from A, that is A1C, we all know, B is blood pressure and C is cholesterol. This is known to everyone, ABC of diabetes. So there is nothing new in that and I am not going to talk much about that here. D is diet. Now someone may argue that if your diet is good, obviously ABC are going to improve, but sometimes a lot of modifications are required in the diet, not only to improve the ABC, but also to reduce the weight, also to reduce the glycemic variability, and also to improve the overall health. Similarly, exercise is also very important regardless of the ABC improvement. For your overall fitness, for your muscle strength, and for your cardiovascular fitness, exercise we know plays a very important role. Coming to the follow-up is F. G is general health, H is habits. I'll just discuss what is general health. I is infection and infection prevention, which is again very, very important area in the treatment of type 2 diabetes. Not everyone dies of cardiovascular disease in India. We know that during COVID, a lot of people with diabetes died because of the infection or the sepsis or some other infection related problems. So infection prevention in our country is extremely important. And finally, none of the guidelines mention that the drugs which we are giving, what care you need to take. Because all the drugs which we are using are not devoid of side effects. We need to explain and educate the patients for prevention as well as early identification of those side effects so that they can notify us and we can do the necessary changes in the medication dosages or change the medications. So starting from A, that is average control, we have just highlighted some of the important points in the blue index. Like in A or the average glucose control, we know that there is enough evidence now that lowering the HbA1c to below 7% can significantly reduce the microvascular complication. Lowering from 7 to 6 is associated with further lowering of the microvascular complications. And if you do it early in the course of the disease, when the person is young, the longevity is quite good. And at that case, if you treat them more aggressively, achieve near normal glycemia with the drugs that do not increase the risk of hypoglycemia, now we have several drugs like that, then you can even reduce the long-term cardiovascular disease rates. Now we have also included the time in range, time below range, above range, being the beneficial parameters, and they are useful especially for the insulin requiring patients or even sulfonylurea requiring patients. These days we know that the agents with low risk of hypoglycemia and cardiorenal metabolic benefits are preferred. So that is all about the A. B, I am not going to detail because we all know the importance of the blood pressure control in person with diabetes, as important as the blood sugar control. The criteria are very streamlined now. 130, 80 or more than that should be treated, and more than 160, 100 should have prompt initiation with 2 drugs. So I am not going into details of this. Cholesterol, again, lot of things have been said and written about the LDL lowering, non-HDL lowering, and the benefits of statin therapy in diabetes patients. We now have additional agents that can be used in addition to statin to reduce the residual risk. So I'm again not going to discuss this because this has been discussed in several conferences time and again. So you all know much better than me in this regards. Here as an RSSDI chairman, what I am going to discuss with you about A, B and C is that in Gujarat, unfortunately, we do not have a very good documentation of the records that how many of our patients coming to the clinic have good HbA1c control. How many of them are on insulin? How many of them are on multiple drugs? So this is a research area which we all can easily take up and produce some data and can publish. So in this year, myself, Dr. Pratap Jethwani and the team members, Dr. Akash Singh, what we are intending is that from Gujarat, we need at least 12 publications, one every year, just based on this data of A, B and C, that how many of our patients are under very good control, how many of patients are not under control. Dr. Jyoti Dev rightly told and honestly admitted that only about 15 to 25% of our patients are actually at ABC goal. Probably the number may be even smaller. Who knows? So by our clinical care, whether we can improve those numbers, and that would translate into reduction in the cardiovascular as well as the microvascular complications of diabetes. In D, that is dietary modification, we have just included 3 factors. The carbohydrate content, increasing the protein content when not contraindicated, and modifying the fat along with fiber and taking care of the sodium supplementation or sodium restriction, whatever is appropriate. In exercise, we know that most of our patients believe that just walking is good amount of exercise, but we know that resistance training is very important for diabetes patients, especially to reduce the cardiovascular risk, especially to reduce the sarcopenia, which we are very commonly seeing in the weight reduction era. More so we are going to see that. So sarcopenia should be prevented, and that's why exercise counseling is very important. Follow-up. So F stands for follow-up. After A, B, C, D, E, F is for follow-up. We know that follow-up of diabetes patients has to be there every 3 to 4 months. And Dr. Jyoti Dev very rightly said that it can be even a telemedicine follow-up. We all can do that. He rightly told that there is no rocket science in that, but we have to believe in that. Unfortunately, we are not rewarded for that. That's a different matter altogether. How to take charges for that, it remains to be seen in future. But yes, telemedicine can definitely improve their overall health. If the patient cannot come personally, you can follow up them virtually also. Now there is significant evidence. When we talked about this in IDF Dubai in a small group of Indians, many of the people argued that how follow-up will be helpful. There is no data that follow-up regularly is going to reduce the complications. But now we have enough data internationally also that low frequency follow-up is associated with poor glycemic control, worse metabolic outcomes and increased diabetes related complications. Here I would like to emphasize that in every clinical visit we should be examining their weight in addition to the other things. We should be assessing their lifestyle. We should be seeing their behavioral changes. Foot examination obviously would be mandatory, and look at the necessary investigations also. At every clinic visit we must be asking about the hypoglycemia, which we often miss, and then patient comes up sometimes with severe hypoglycemia. Follow-up gives you opportunity to understand the patient's psychological as well as the family bonding and the other problems that patient may be facing in a better way. Moreover, it also gives you a chance to look at his medications. Number of times, if you have prescribed 7 or 8 medications, patients may be taking 2 or 3. Statins we have seen are the commonest medication which is missed by most of our patients. So unless you emphasize the importance of the medication adherence, whatever prescription you have written is not going to be beneficial for that particular patient. G stands for the general health improvement. In general health also there are 6 aspects which in a diabetic patient we must look into. Anemia is not uncommon in diabetes, and anemia can be due to several reasons and it affects the quality of life. It is associated with increased cardiovascular risk, hypertension, retinopathy, neuropathy and even chronic kidney disease. And moreover, anemia these days you have to investigate, especially if it is there in males or elderly male, sometimes GI malignancy may be there. Bone and musculoskeletal health are also assuming great importance now in the weight reduction era, so that also should be looked at, if possible by body composition analysis, if not by at least hand grip. Cancers are also increasing because we are living longer. So some of the cancer which are insulin resistance related, like liver cancer, pancreas cancer, colon rectum, breast cancer, bladder cancers, no need to investigate them every time. But at least if there are symptoms suggestive of that, we should be looking into. Diabetes distress, Dr. Subhash Kumar talked about that in detail in the morning, that diabetes distress can affect the person with diabetes. It can affect their control, their follow-up and their quality of life and the medication adherence also. So diabetic distress also you can make out through regular follow-up. Endocrine diseases I am not going into detail, but thyroid diseases should be investigated because they are very common in type 2 diabetes patient. And finally F, fatty liver disease. 50% of our diabetic patients are having fatty liver and many of them develop MSLD or may go on to developing cirrhosis or even hepatocellular carcinoma. Not a great number, but fatty liver disease is very, very common, and FIB4 score according to the ADA guidelines also must be calculated in each and every patient. You do not require more investigation for FIB4. You just require AST, ALT and platelet count and patient's age and you will get the FIB4. Less than 1.4, no need to investigate further. Again, habit cessation, smoking, tobacco chewing, alcohol, and now new habits are also coming up. No need to go into detail. We all know the importance of habit cessation or avoidance in diabetes patients. Finally, infection prevention before I go on to the Jeopardy. Infection prevention is very, very important in diabetic patients, especially the periodontal infections we never look into. And periodontal complications are 6th important vital sign or 6th important complication for diabetes patient, because it is associated with not only higher HbA1c level, it worsens the glycemic control and it also worsens the cardiovascular risk through inflammation most probably. The respiratory infections do also occur, very common in diabetic patients. Influenza vaccine, I think less than 5% of our type 2 diabetic patients may be taking influenza vaccine. Correct me if I am wrong. So the importance of influenza vaccine is also very much there in addition to the pneumococcal and the other vaccines. But I think influenza vaccine is not expensive and should be annually administered to most of our diabetic patients who are age 50 or above. And genitourinary tract infections have only increased in the SGLT2 era. Not that SGLT2 are associated with more risk of that, but proper hygiene or prevention or early identification should be educated to the patient and family members so that they can easily take care of that. Finally, coming on to the adverse drug reaction education or the Jeopardy education. Since it was A, B, C, D, E, F, G, H, I, we thought J or Jeopardy just to complete the ABC list. Hypoglycemia, all of us know, associated with sulfonylurea and insulin, but very few of us really educate the patient. Hardly it takes 2 minutes from us or our counselors to tell how hypoglycemia can be prevented, identified early, or treated at home. Lipodystrophy, again, very, very common in insulin taking patients. Thanks to Dr. Darjani and Dr. Padmanabh who are here at my clinic, they very regularly look at the lipodystrophy, and more often than not, type 1 diabetic patients, they develop lipodystrophy, and that is one of the reasons for their glycemic variability or fluctuation of the sugar levels. So this must be seen at every clinical visit whenever the patient is taking insulin. And genital infections, we know, urinary tract infections, we know, should be identified early, treated and prevented by proper counseling. Patients on pioglitazone should be informed about weight gain and fluid retention. So these are the things which are very, very important in clinical practice, which should be educated to the patient. It does not require much time though. All these factors together will not require more than 10 minutes. So these 10 parameters, if you give importance to this every minute, just 10 minutes of your counselor is required. If you are busy, your counselor or your educator or your nurse or your colleague can very easily explain this in just 10 minutes. We can also calculate the score when feasible, but even if you do not calculate the score, all the aspects that are included in the comprehensive care of type 2 diabetes according to RSSDI, according to ADA or any of the guidelines will be included in this A2J. Thereafter comes the complications. We have divided them into 3 categories: the cardiocerebral or macrovascular, renal and retinal, that is microvascular, and foot we have categorized separately, because foot is not just micro, foot is not just macro, it is a combination of micro, macro, bone related problems, muscle related problems, skin related problems, infections. So many things are associated with foot complications, and that's why we have categorized it separately from the micro and macrovascular complications. So how we express the blue index? We express it as diabetic health score. Higher the score, better it is. Slash, it is not a division, slash complication score, that is cardiorenal and foot complications. Lower the complication score, better it is for the patient. Higher the health score, better it is for the patient. There are some publications on that regarding blue index. The strength is, it is not a risk score. So suppose someone is having a score of 40 and some other person is having score of 45, it does not mean that person with 45 is having less risk of complications compared with patients with 40. But some person, if the score was 30 previously, improves upon the areas where the improvement is required, will definitely have improvement in the score, and that would in the long run reflect into better quality of life and probably reduction in the complications. At present, we do not have a very hard evidence that it will reduce the complications. Maybe in the coming years, 2 or 3 years, because we are working on this for last 7-8 years, since 2018. We now have about 7 years data, and we have clubbed it with one another project, that is Happy Project. I'll just share with you. But it provides continuous patient education and motivation. It is a strong tool for holistic education of the disease status, complications and overall health. It comprehensively covers the glucose control, the vasculometabolic and renal health, and the general health, and it gives equal weightage to patient efforts as well as our treatment targets. Our targets may be different, patient's goals may be different. So it is respectful of the WHO definition of health because it is giving the overall, it is having a holistic approach. Till now, in last 4 and thereafter subsequently 3 years, we have calculated it more than 3,000 patients. Dr. Dharmendra, who is here, may be having even more number of patients. Dr. Dharmendra, are you here? Complication score we have calculated in more than 2,000 patients, and the complete data of more than 3 visits over 12 months is available for more than 1750 patients. This is our website. And in one slide, I have just given you a brief summary of how much improvement we have seen in this course. You can see this is A. From baseline of 21, the score has improved to 66. In the blood pressure, the score has improved significantly. In the lipids, the score has improved greatly. In the diet, patients have been more motivated to follow the diet. Exercise, we have not seen great improvement, but yes, improvement is there. In the follow-up, this is comparison of patients whom we discussed about this index and explained them the benefits, and compared to that, those patients whom we provided standard of care without explaining them the blue index. We educated them in all the aspects, but not the blue index. Not that we did not educate them for the hypoglycemia or all the important things, but we did not mention about the blue index there. So in comparison, you can see that the blue bar is better in every aspect compared to the bar in the green color, which means that encompassing the blue index in our clinical practice will definitely improve the patient's overall health and their motivation and their engagement in the disease. You can see that the score of 34 at baseline improved to 40 in the blue index group. In the other group, in the non-index group, the score of 35 just went up by 1 point, that is 36. So a significant statistical improvement in the blue index patients compared to the non-index patients. At present, we do not have any evidence that it will reduce cardiovascular or microvascular complications. But we have clubbed it with one of the other project, that is HAPPY project. We are going to publish it soon. And we have seen that there is a significant reduction in the trend towards cardiovascular as well as other complications. Someone may ask that why you have not included all the patients in the blue index group. Well, blue index is not standard of care. We wish that it becomes standard of care. So at present, there is nothing ethically wrong if you have not included the blue index group. We have given equal weightage to every parameter because at present we do not have any evidence to show that one parameter is greater than the other parameter. At present, we do not have any rate, complication rate and mortality data available. Is it very time consuming? It just takes 5 minutes. First time it will take about 8 to 10 minutes. In the follow-ups, it will just take 5 minutes. Many of our centers are using it now. We have several publications also in the Journal of Diabetes, in the Journal of Clinical Diabetology, and in JAPI also, Dr. Shambhu Samrat also made one publication there. So finally, at present, we have seen significant improvement using the blue index. Very importantly, patients are interested in that. Patients themselves ask that whether my score has improved or not. Not much improvement we have seen in H and J, that is habits and the Jeopardy, but patient empowerment, we are definitely seeing their involvement, engagement in their own healthcare, and it has made the jobs simple. Thank you once again, RSSDI Gujarat chapter, Dr. Jethwani, Dr. Parag, Dr. Akash Singh, Dr. Dishang for inviting me and giving me this opportunity. My acknowledgements, Dr. Bansi, without whom this would never have been possible. Everyone knows anywhere in India, if you want to do some good research work in diabetes, you need Bansi's advice. Dr. Dharmendra, Dr. Dhruvi, I can see Dhruvi here, Dr. Padmanabh, Tarjani, Vipul, Rutul, Piyush Bhai, Dr. Shailesh Bhai, Manoj, all the colleagues, and Dr. Urman Bhai Jitendra for helping me, supporting me at every point during development and processing this blue index. Thank you very much and Jai Hind.